about it, right? So let's start with the stage is set by Dr. Mathur. This won't change. Then it's all right. So now I've made you all ophthalmologists, I've passed you all, right? Now a patient comes to your clinic, sent by some doctor, and he comes with visual field. Now, will you make a diagnosis like Kirti said, they come on OCT, they're being treated. So will you treat it on visual field or you'll want to do something else? It's your turn. Santosh asked me to make this class totally interactive. You will answer. I am a patient. I have come with visual fields of right and left eye. I have come to the clinic. Now what are you going to do? Clinical examination. Very good. So what all will you do in that? Clinical examination bola to that covers everything. You've done the clinical examination. Now you found something somewhere. So what all is it that you are dying to connect with visual field? Manoj said that. Optic disc, right? So let's look at the optic disc. Now these are the patient's optic disc. Please have a look. So anybody, what do you see here? Huh? Where? Good. Now, in this patient, where should the field effect be? All right. But is that enough? What do you see on the right side? Just look at it more carefully. What is up there? Pupil is dilated, so who sent this patient to you? Retina specialist. All right. Now, is there anything else? Right? You're correct. So now will you accept this field on the face value? No. So what are you going to do? Undilated, we will repeat. All right, good. So now, suppose you've done on this. What are you likely to miss? You've done it 11.5 millimeters. What are you likely to miss? What is the disadvantage of dilated pupil? What? What will increase? Even if it's slow, it will increase in this. It will look falsely a better field, right? And then you cannot have like this forever. Normal pupil size will remain normal, consistent always. Dilated could be 6 millimeter dilated, 11 millimeter, 8 millimeter, so every time it will be different, right? What else is missing? Something missing up there. Visual acuity, perfect. Why do we want this visual acuity? Yes? One person, answer quickly. These are very small questions, very basics. Two? Say clearly, can't hear, it's a little louder. Could be, but this field is not depressed. Still we need it. No, presbyopia or refraction, they will put some glasses somewhere. They put glasses already. Is there anything we connect visual acuity with that's very relevant in a visual field? Retina man has sent the field to you. No. Retina person has sent the visual field to you. What is the foveal threshold out there? How does this relate with visual acuity? Suppose this patient has visual acuity of 624. Suppose he has 624. The previous person was right, there could be refractive error. But the same patient had 6 by 6 and there 25. what will happen? It's a macular disease, right? So you have answered all of them right, so all of you chocolate. Right? Now, what are you seeing that arrow on top? It's in front of what? Test duration. Is it all right? Less or more? It's okay. It's theta. All right? It's good. Patient is good. It's theta test. It's not like, it's not a threshold. Tell me, in this visual field, normally where do you see reliability indicators? On top. Is there anything else in this visual field that is showing you reliability indicator, which is done far more times? It is done hundreds of times rather than those few, 10, 15, something like that, fixation losses or something like that. Is there anything in this entire field, look up, down, all over the place? Huh? What? Yes. Speak, speak. What's that? Yes, so these are what happens here. Why do these spikes come? Where are they taken? They're taken on the cornea, right? On the center, so when the eye is moving, the image will be taken from the cornea only. This is actually a more sensitive indicator than those. Many times you will feel in clinical practice, all that looks normal, but the field is not normal, the patient doesn't have anything to prove. So not look there only, look here as well, right? Now you see something out down there, a VFI. So what is VFI? So how's that made? Anderson criteria doesn't say VFI, it says MD, right? But that's actually a little old now. VFI is something much better. So how does MD differ from VFI? You have one more session, after this. So if you don't activate yourself for next 2 hours, there'll be a challenge, right? So how is MD and VFI, they differ from each other? It's very vital. You see these two things here, one here and one here? I want to make it very simple for you. The sum of this divided by the numbers is your MD. So therefore, MD will be reduced in any damn thing, is corneal opacity, is a cataract, is whatever. Now what's this? Pattern deviation. So VFI to pattern deviation is same as what MD is to total deviation. Therefore, what are you going to get in this? It is more specific glaucoma loss. Where will be the fallacies? Nothing is without fallacies. Tell? If the total field is so depressed that you're not getting pattern deviation. No, if it's so depressed, then you will not get decent VFI numbers. All right? Now in this patient, you're seeing something right in the center out there. So now what will you order? 10-2. Why 10-2? Here, what is the problem? Why do we take a 10-2? We are taking how many points in the center? 10 degrees? How many points in central 10 degrees? Huh? Central 10 degrees in this field, how many points? Not 16 points. Come down. Come down. Go home and check. I will not tell you everything here. Okay? Don't go on the total numbers. In 10-2, how many you have total points in 10 degrees? At least 10 times higher points than this. All right? What else will you keep in mind? It's right there in the center. Every patient who comes to Roy doesn't tell you, I have glaucoma. I can have something else also. Patient doesn't tell he has glaucoma, she has glaucoma, we decide, right? So one more thing you have to keep in mind. When is something like this, only involving one quadrant, I'm not saying it is, but just keep in mind that neurofield is a very much possibility. So what is here? Huh? What? Are you looking at the pupil diameter now? It's the same patient on pilocarpine for last 30 years. This is pilocarpine for last 30 years, that eye, 1 millimeter pupil. Maximum dilatation is 2.5 millimeters. Right, so this is the impact of pupil. So large pupil is not as bad as is the small pupil. Chandrima, whenever time gets over, just let me know, because I just kept it like. So what do you see these two fields? Are they different or the same? Yes, somebody said 24 to C. What is 24 to C? What is this field? This will come in your recent advances. It's in Humphrey 840 onwards. Sita faster. You have Sita and Sita fast. This is Sita faster, right? So, you're right. But what is special about this field? Is it only faster? Or there is something else? Yes, 10-2 component, but how much of 10-2 component fitted in this? Just 10 more points have been added in the center. So one thing is, it's something nice to have, something newer to have, but caveat is as good as Sita, but actually it's not as good as N-2. There is no evidence-based study that says that it is as good as N-2, right? So you can use it as on today. You can use it in lieu of Sita, but not in lieu of Sita, not in Sita 24-2. But not in lieu of 10-2. 10-2 still stands as good as before. The good thing is the time taken. Test duration is almost to half. Therefore, you can do for many more patients. These days, costing of machines, Humphreys raised the cost by double. So in one day, you can pool in. Another thing is, don't each one of you buy a visual field in your clinic. Pool in, learn to pool in the equipment. You will have a lot more. Now here, in a field like this, when macula is threatened, what do we do? Very important, Kirti is to operate a patient, 24-2 is done. Now she is worried about something, that whether I should do a trab or not do a trab. So it's telling me that the time is over, I think. I think I'll finish with this because the time is over, right? So now tell me what is there. She knows everything, but still she's not comfortable, this macula is threatened. What does it mean by threatened? Yes, I'm hearing the word right. Speak. Split, it's a split. Is it a split or not split? Again, you go back to 10-2. If it's a split, then think twice, do a good counseling that this snuff out or wash out is a possibility. It's not that it will happen in every patient. It doesn't happen often, not more than 1 in 1,000 patients, but it happens, right? So the counseling has to be different. So with that, I'll say bye to you because my destination to write has been told to me. Now I think all the people are there, so you people can have your questions, or I think the consultants should ask them questions because they're not